An increasing number of patients are presenting at dental offices with severe occlusal wear. Traditional techniques are complex and expensive and often leave a patient with little choice than a full clearance. The technique I will demonstrate involves building up the anterior segments between the first bicuspids with composite resin on the upper and lower arches. This will form a fixed occlusal splint. After about 3 years, super eruption will stabilise the occlusion. Compared to traditional techniques, this is a minimally invasive, simple solution to a complex dental problem.
This patient presented with a severely worn dentition. After considering her options, she decided upon a direct composite resin build-up. Sodium bicarbonate is the antidote for trichloroacetic acid burns. TCA chemically cauterizes gingival tissues and prevents cravictor exudates. The white eschar formed disappears within 2 hours. Teeth are etched with 37% phosphoric acid for 10 seconds. Next, they are flushed with water and dried with oil-free air. Fujibond LC is brushed over the central incisors to form a flexible adhesive base for the future laminates. The bond is spot cured for 5 seconds. An increment of cervical shade microfill composite resin is puddled in at the gingival margin with a Ward's carver. Spot cure for 5 seconds. Fujibond LC is brushed over the upper right lateral incisor and canine. Spot cure for 5 seconds. Cervical increments are similarly placed on the upper teeth between the first bicuspids. Resin bond is brushed over the cervical increment and labial 2 surface. A body shade microfill resin is now puddled onto the surface with a Ward's carver. After making several small grooves on the surface of the uncured resin, a white tint is placed onto the surface and characterized into the laminate. Spot cure for 5 seconds. A similar process is carried out on the right lateral incisor, followed by a 5-second spot cure. The same procedure follows each of the remaining upper teeth, followed by a spot curing of 5 seconds. Resin bond is placed over the incisal third of each laminate. An enamel shade microfill resin is placed over the incisal third of the upper right central incisor. A similar increment is placed on the remaining upper incisors. An increment of fibre-reinforced resin, Nulite F, is placed on the lingual surface of the upper right canine. It's spot cured for 5 seconds. A similar increment of Nulite F is placed on the occlusal surface of the upper right bicuspid and spot cured. A wear-resistant resin, Heliomolar, is placed over the Nulite F and worked to form a flat occlusal plane. A similar procedure is performed on the left-hand side. Spot cure for 5 seconds. A paper point is gently inserted between the 2 central incisors and a mylar strip wedged into place. Bonding resin is dabbed interproximally. An incisal shade microfill resin is placed interproximally and worked over the incisal edge onto the lingual surface. The mylar strip is wrapped around the tooth, stabilised with a Ward's carver and spot cured for 5 seconds. A similar procedure is carried out on the upper left central incisor. Care being taken in positioning the midline. After forming the midline, the distal margins of the upper centrals are constructed. Once a paper point has been inserted, adjacent proximal surfaces are placed. Special care is required with the canines and bicuspids due to the wide proximal spaces formed. Attention must be taken to fill these proximal spaces up completely with resin. The paper point will prevent overhangs, so composite can be aggressively worked in from both the facial and lingual surfaces. The proximal areas are cured on both facial and lingual surfaces, each for 10 seconds. A similar technique is employed for the remaining proximal surfaces. The further distal the laminates are, the more challenging it is to place them. The same procedure is applied on the left-hand side, and each laminate is cured for 20 seconds. Minimal initial contouring is commenced using a Moore's extra coarse emery disc. Cervical contouring is carried out with a coarse, high-speed diamond point on both facial and lingual surfaces. The lower arch is now etched, washed and dried as the upper. Similarly, the canines and first bicuspids on the right hand side are created and cured for 20 seconds. Using a cotton wool roll for isolation, the lower incisors are coated with Fuji bond and spot cured for 5 seconds. After a further coat of Fuji bond, an increment of hybrid resin is placed at the incisal surface and spot cured for 5 seconds. This is repeated on each lower incisor, building up to the occlusal plane formed by the canines and bicuspids. After a further layer of bonding resin, an increment of body shade microfill resin is placed on the labial surface. A small amount of white tint is placed and characterized into the resin with a Wurtz carver. Spot cure for 5 seconds. Keeping the paper point in place, the adjacent proximal surface is similarly prepared. After each proximal margin has been formed, paper points are removed and each incisor is photo cured for 20 seconds. Contouring commences by flattening the occlusal planes with a Moore's extra coarse emery disc. The patient is shown where to place her tongue for a retruded occlusion. Further contouring of the upper and lower planes is carried out. Cervical contouring is carried out with a coarse diamond point. The same burr is used to contour the lingual margins. The same technique is used for contouring on the lower arch. Magnification will ensure reduced trauma to the gingival tissues. Occlusal and incisal contouring is carried out with a Moore's fine emery disc. This disc is also used for contouring the lower arch. Proximal contouring is done with an abrasive metal strip in each proximal area. dental floss confirms the absence of proximal overhangs. Proximal finishing is completed using flexible abrasive strips. Washing down the site shows the emerging laminates. Proximal finishing is commenced using coarse interproximal softflex discs. Reversing them improves access to the proximal areas. This process is carried out with minimal trauma to gingival tissues. Facial contouring is commenced using a 12-fluted tungsten carbide burr. This burr may also be used on the lingual surfaces. A 12-fluted tungsten carbide burr is also used for the lower arch. Articulating paper is inserted, and with the lower jaw in a retruded position, centric, protrusive and lateral movements are recorded. Prematurities are removed on both upper and lower arches with finishing discs. The occlusion is again registered with articulating paper in protrusive and lateral movements. Further interferences are removed on the upper and lower arches. The edges of the lateral build-ups are spheroided over using a small, coarse, softflex disc. Final contouring of the lingual surface is carried out with a slow-speed diamond sphere. Facial contouring on upper and lower arches is commenced with a high-speed, pear-shaped mounted stone, using rapid movements in the long axes of the teeth. Finishing is commenced with a coarse silicon rubber cone. Followed by rubber wheels using increasingly finer grits. The same procedure is carried out on the lower arch. The use of abrasive discs should be avoided to maintain surface contouring. A final polishing is given using an extra fine softflex disc. This shows the completed build-ups. Note the balanced occlusion in both lateral and protrusive movements. Observe how the occlusion has been opened to the extent of 3 to 4 millimeters. Over the next 3 months, small occlusal wear patterns will develop on the occlusal surfaces of the canines and bicuspids to produce a fully functional occlusal table. New teeth and a slightly elongated profile has dramatically enhanced the facial aesthetics of this lady, producing another happy patient in the practice.
Some practitioners may find this procedure a little daunting. However, the steps are sequential and can be carried out over a number of visits if required. Patient feedback is truly positive because not only have they improved their smiles, but in many cases they've eliminated TMJ and neck pain as well. If you'd like some more information about this technique or other videos in the series, I can be contacted on the following email or fax numbers, or check out the website. And thanks for watching this video.